Hello. I guess we're open up to panel discussion now. There was some very exciting talks and a lot of information. So let's, once we switch to the panel mode, we can start our webcams and open it up to questions from the audience. I've seen the audience with a fair amount of questions. One that caught my attention right away was, if one of our speakers was having a procedure done and needed it, which one would we use? And my answer to that was, depends on who's doing it. If doing my veins, he's doing laser.
No, that's not true. I think you have to be specific on that question, because there is no one device that's perfect. There are devices that you can use in many different applications, and there's some devices you can only use in some applications. The indications now are different than all of them, but essentially they're all good, they all work, and it really depends on what vein I'm treating.
Exactly. So, for me, if I would first pick the person who understood the pathophysiology and what exactly was wrong with me very well. If it was a straight sapness, whether lesser or greater, laser works, RF works, initial works, and foam works. Recently, I've done a lot of foam, so I'm become very good at it and done very quickly. Patients seem to have good, so somebody very experienced with that, I would do it. If there were tortuous branches, etc., laser can't get it all the way up. RF can get it up. Venocell can get it up, and then foam becomes a game player. So Lowell, you're right. I think it depends on what you have and what's the right point for it. So, I think there's some specific questions about the glue as well that were popping up, and I'm sure you can see it as well. We can definitely address some of those questions. One of them was, can excess Venocell embolize?
Well, I'll leave Morrison to it, but on the 30 patients that we looked in the Dominican Republic that we just published a 3-year follow-up, 3 years later, we don't see any. There was no embolization on the patients we did, and 3 years later, the veins, most of the veins were closing. You don't see any remnant on the cyanoacrylate on the treated location. So we didn't do any biopsies on none of them, but by ultrasound, you don't see any residual of the glue within the vein.
So, Javier, are you saying that you couldn't even see the adhesive at 3 years?
No, we didn't see any adhesive at 3 years.
Within the vein, you couldn't see any at all.
Well, we saw the vein close, and certainly there was on the ultrasound device you could see that there was brightness in there, but it just looked like a closed vein.
It didn't change from 1 year, 2 years, 3 years. It looks exactly the same. I just wrote an answer about what's the fate of the cyanoacrylate, and at this point we don't know. We expected it's going to be resorbed, but we're waiting. We don't know. The other thing about embolization of adhesive is that stuff is so viscous, and it sets up, it polymerizes so quickly. I think it's extremely unlikely that it's going to embolize. That is certainly not to say the same for the Turkish adhesive. That stuff is water, or same consistency and viscosity as water. So I would worry about that, although I, again, don't have any experience with it at all. But embolization would be more of a worry for me for that product than the Venocell.
Nick, I've had experience with both products now, and you're exactly correct about the viscosity of the Turkish glue. But again, when we're looking at embolization, nobody knows the fate. Nobody's gotten any chest x-rays that I know of. And really the amount of embolization or thrombus or even that little sphere is going to be so tiny that they're going to remain asymptomatic. So I don't think anybody's going to look for it. And the same thing with endothermal heat-induced thrombosis. We know that some of those embolize too, but they're asymptomatic and the thrombus burden is not rich.
Yeah, so there's a couple of questions there about can you feel it? Patients, I haven't found a patient yet who was able to feel the adhesive afterwards. Having said that, we were careful about being sure that the veins that we treated were well below the skin surface. Kathy has now treated some that are quite close and has the same experience. That is, patients don't seem to feel it at all. Do we compress the saphenofemoral junction with VenaSeal? Absolutely. So the first thing that's done is saphenofemoral compression and then small dollops of adhesive at 1 centimeter intervals and allow it to set up for 3 minutes. After that, it's solid. It's not going to go anywhere.
So Nick, the amount of VenaSeal that you're using per great saphenous vein is small, right? Well,
very small. It's the average in the study was I believe it was 1.3 or 1.6.
1.2.
So there's not much at all. You can treat a 30, 40 meter segment with that centimeter segment with that 1.5 ml of adhesive.
Yeah, and what happened when we treated was that these veins really spasm significantly. So it allows you to use a lot less cyanoacrylate. So they become so small and the lumen becomes so small that makes it easier to get the vein walls compressed against the catheter and the glue.
There's a $1 million question that occurred, Dr. Chopra, about the cost of these products.
Yes. So I think, it's obviously in our practices, we all see it. It depends on which insurance is paying for it or not. I know that the reimbursements for RF ablation and laser, especially Medicare, which is kind of sets the benchmark, if you would, has dropped significantly. And then most patients have a 20% copay. If they don't have that secondary, that tends to kind of also go by the wayside. So I know that a lot of these have become commodity items, and the laser, both the laser and the RF, are kind of in the $400 to $500 range, I believe. Some may be a little much higher. I don't know much about VenaSeal. I'll let one of you address it, but I do know with Varicose, the insurance companies are approving it. Almost every commercial insurance is. Some from specialty pharmacy will get a canister, which is specifically for the patient. So they actually send you the canister for the patient, just like any other drug. But you can, as a practice, also purchase it. And you can use it for 3 to 4 patients, often depending on, there's about 75 cc's in there. So you can land up using it for 4, maybe even 5 patients sometimes. And it can keep the economies of scale. Right now there is no code for the foam treatment, but it is crosswalk to ablation. So I think there's been decent reimbursement for that as well. I don't know if
right now,
Romi, can I ask you? So you don't use any more compound sclerotherapy for towards your GSV. You're completely in paresthesia now.
Yeah, mainly we use. Occasionally, it's because I have enough of Varicose with me, and I'll land up even on the on the SEEP1s, on the telangiectasia, if I see a reticular vein, I'll use the Varicose. But for that very small amount, I still use physician compounded, use the Tesari method, create my own foam. But for the large saphenous branches, like a couple of the cases that I showed, it's all Varicose now. And with good compression, the result is remarkable.
So
now, for those that are listening, this is a location that is very busy, and you're going to be able to use the Varicose before it expires, which I think is now 21 days. Is it that you're able to?
No, it's much longer. It's over 90 days now. And
90 days? Okay.
Yeah, it's over 90 days. And then if it doesn't, you send it back, and the specialty pharmacy will send you another canister for that patient. And the company's been very good about advising and supporting with that, but essentially, my staff will have the prescription, it goes out, the drug shows up in, and then you don't bill for the drug anymore. You bill just for the procedure. If you purchase the canister yourself as a practice, then you bill per PT. And it depends on the insurance, they'll reimburse it. Medicare is kind of tricky. Different areas reimburse differently as far as how this is reimbursed. But there are certain patients, like the two that I showed, I couldn't use laser, I can't use RF, I can't use VenaSeal, and those are the kind of complicated patients that I've found them using a lot of these, especially in the C5, 6 categories, getting some remarkable results there.
So for everybody out there, in terms of codes and things, Clarivain has received their code. They have their RVUs. In 2018, more than likely, both VenaSeal and Varithena will receive their codes and RVUs. But that being said, the insurance companies may or may not adopt them. And we're seeing that right now, where most societies are in favor of the non-thermals, trying to help the companies through that.
Any other questions that stood up to?
However, I do have one more comment. I would say that for the next several years, I think thermal ablation will still be the gold standard. I do see that when we talk about economics, we have to be very careful of what we're doing out there in our reimbursements, and really what the advantages are of non-thermal. So I think that there are certain advantages, especially when we look in the below the knee, when we're looking at distal small saphenous, distal great saphenous veins, because of the nerve particular injuries. And when we look at C6 patients, I think that there's certainly an indication for Varithena. That being said, probably very good, because we can then take care of the ulcer bed at the same time. So I think there are certain indications with that, and I look forward to that. But remember, what are we doing for a typical great saphenous vein that's straight? You know, the advantages of thermal are there. So you have 6 to 8 needle sticks maybe. And if you're doing phlebectomy at the same time, if you're one of those and not staging, then you're also going to be giving tumescent anesthesia there too. So that may not be something that you would stray to. But if you're a stager, and a lot of people do stage, and I'm a selective stager, then these non-thermals may be really advantageous. So again, it depends on what you're treating, where you're treating, and the like.
Yeah, so I think to add to that, Lowell, I would say these are all tools in the toolbox. We'll see what the objective is for the patient, what's his problem, how can we solve it, and then take the best tool at the best price and so make it better, faster, cheaper, and get the best outcome we can. So in our practice today, I use RF, I use laser, we use a lot of Varithena. We haven't started with VenaSeal just yet, waiting for reimbursement issues to get resorted out. We have patients who come in with self-pay models as well. So it's all about adding value and solving it, and all of these are in the toolbox. It's not one versus the other. It's what's the best thing you can do for them. Excellent. If not, I think we've reached the end of our time. And thank you to all the different presenters in the audience. This is a recorded session, so I'm sure all of this will be available to attendees and others through part of MIMIT. So thank you again, everybody, and have a great night, and I hope we'll all catch up soon.